Okay, good afternoon, everyone. I hope everyone's day 2 has gone very well. I am Julie Taft. I'm the Humanitarian Director with International Planned Parenthood Federation, IPPF, and really pleased to be with this terrific panel today. We are going to be talking about family planning for adolescents in emergency settings, and we have a terrific set of presentations for you ranging from all different parts of the world. So we will be presenting, and then we'll have an opportunity for discussion and Q&A and reflections from all of you following the presentations. I would first like to introduce the panel. We will start at the end there with Sigma Anul. Sigma is the Senior Program Officer with Population Council, and she will be presenting on family planning use among Rohingya adolescents. We then have there Muri Taupan, who is Executive Director of one of the IPA chapters, the Indonesian Planned Parenthood Association, which is also an IPPF partner, and she'll be talking about peer education to promote family planning in the tropical cyclone Saroja response. Here we have Pari Chaudhry, who is joining us from CARE. She is the Senior Technical Advisor, and she'll be discussing reproductive health for married adolescents in Syria. And last but not least, we have Herbert, who is joining us from IRC Uganda. He is the Health Project Coordinator, and he'll be speaking about family planning services in the humanitarian context in Uganda. So Herbert Mahumuza, thank you very much for being here. Okay, I think many of us have probably operated in humanitarian settings for many years. Perhaps it's new to some of us, but I see some familiar faces here. And I think it's fair to say that reaching adolescence can be challenging. They can be diverse, and there are different strategies that are employed in different places. And while we'll be hearing about specific contexts today from our presenters, it'll be really interesting to hear other reflections from the group and see how we can learn from these experiences to address ongoing protracted emergencies and new ones that crop up to make sure that we're meeting this important segment of the population. That said, I think we'll move into presentations and hear from the experts. We'll start with Pari, please.
Hi, everyone. My name is Pari Chaudhry. I'm the Senior Technical Advisor with CARE USA, and today I'm going to be talking to you about the Adolescent Mothers Against All Odds, or as we affectionately call it, the AMAL initiative. AMAL was an approach that was developed specifically for first-time mothers and pregnant adolescents in crisis settings to be able to get them to improve their sexual and reproductive health. Today, I'm going to be speaking about our lessons that we've learned from the implementation of AMAL in Syria and in Nigeria. But before we get into that, I'd like to first talk to you about how AMAL started. So let's all take ourselves back to 2015 for 1 second. Syria in 2015 was experiencing an established, protracted humanitarian crisis. We had already started to see impacts on young girls because of the long-term effects of gender-based violence, about lack of access to sexual and reproductive health services. We were seeing increases in rates of adolescent pregnancy and rates of adolescent maternal mortality. So UNFPA at the time was convening a group of organizations who were working in Syria, and they came up with this document that you see on the screen, which is called the Whole of Syria Adolescent Strategy. This happened in 2018, and in order to develop this strategy, they went out into the field and asked adolescent girls, what is it that you need organizations to commit to in the next 10 years to really improve your reproductive health? And that was the inception of the AMAL initiative. So UNFPA partnered with CARE and another organization called Syria Relief and Development, and based on this strategy, came up with what we now call the AMAL initiative. AMAL is made up of 3 components. Each component correlates to the target population that the program caters to. The primary target population makes up component 1, and that is young girls between the age of 10 and 19 years who are either first-time mothers or are pregnant. And component 1, which you see on the screen in front of you, is called the Young Mothers Club. The Young Mothers Club is an 8-week curriculum designed for those girls where we cover topics like negotiating sex with your husband, talking about birth spacing, nutrition during pregnancy, danger signs, that sort of thing. The idea is that over the course of these 8 weeks, these girls are receiving an education in sexual and reproductive health, in family planning, and how to have interpersonal skills where they're negotiating with their families and their partners. There's a second piece of component 1, almost like a bonus add-on. It's called the UML Adolescent Leaders. So girls who go through the 8-week Young Mothers Club curriculum and then graduate and say, hey, I'm still really interested in being involved in this program, they're enrolled in an additional session that is a 3-week curriculum where they receive training on how to be leaders within their space. So how are you representing your voice among your community members? How are you speaking for other adolescent girls? And that group of additional girls are called the UML Adolescent Leaders. Component 2 engages the girls' societal and familial networks. So we recognize that you can't really create change for adolescents without also changing the people around them. And so component 2 works with community members and influential key stakeholders in the communities of the girls by engaging them in a 7-week-long curriculum that essentially uses reflective dialogues to get people to ask themselves, why do I feel this way about family planning? What is the role that I play as a key stakeholder, as a community member, as a religious leader in girls' ability to exercise their reproductive rights? So through those reflective dialogues, the intention is that we are getting the girls' community to also come along this journey with them and say, not only are we changing the girls' education levels and awareness levels of family planning, but we're also changing the environment within which they're functioning. Finally, we have component 3, and component 3 targets the health providers that the girls then see when they go to clinics to access healthcare. And so the health providers are engaged in a 4-week-long curriculum where they're essentially asking what are their own biases in terms of providing adolescent-friendly services, how can the clinics that they're in be better designed for adolescents, and questions like that. So the intention there is that over the 4-week curriculum, the health providers are better poised and better skilled and better trained to then be able to see adolescent clients. And all 3 groups then come together once a month in what we call the community advisory group, where the girls are able to share their direct voices and experiences with their community, with their health providers, and the whole group together is able to give CARE, or whoever is implementing UML, direct feedback about how to improve the program. And just a quick note to say that this is the UML initiative. It has looked like this since the very beginning, but there has been a slight evolution over time. So the UML initiative started in 2018 in Syria and has since then scaled up across multiple sites and multiple regions in Syria, and then also expanded now into Nigeria. And we are currently at a point where CARE is handing over implementation of the UML initiative to other implementers in Lebanon and Jordan as well. So one of the questions you might ask yourself is, if we're doing this in so many different countries and contexts, how are we maintaining fidelity of this program? And so I want to just briefly share what the UML initiative curriculum and toolkit entails. So the way in which CARE, UNFPA, and SRD created this program was to bring partnerships with multiple organizations like Save the Children into focus and say, what are some evidence-based approaches that we know work with adolescent girls? And through that partnership process, we created the UML Initiative Toolkit. The toolkit, as I mentioned, includes the curriculum for the 3 components, so Young Mothers Club, community members, and health providers. But it also includes a standardized set of evaluation tools that any implementer can use. And the standardized set of evaluation tools also come with their own set of data analysis templates, which makes it really easy to standardize data if you're implementing across multiple contexts, even if you're adapting the program slightly. So what this allows us to do is it allows us to collect program impact data across all of the sites where we're implementing. And that's what I'm going to share with you now. So I'm just going to quickly share that in Syria, where we started UML, we have 6 different implementers of the program. So CARE partnered with local organizations who are then implementing it in Northwest Syria. And they are each funded either by BHA, which is USAID's Bureau of Humanitarian Assistance, or the German MOFA. And it has been going on since 2018, but the results that I'm about to share are from 2020 onwards. And you'll see that we've had participants across Northwest Syria engaged with Amal. We've had 811 girls, 732 community members, and 142 health providers. In Nigeria, we as in CARE, is the main implementer of the Amal initiative currently. We were funded by UNFPA starting mid-2021 and operate primarily in Borno State, which, as if you're familiar with Nigeria's context, is where Boko Haram usually operates, which makes it a crisis setting. So since 2021, we've had 288 girls participate in this program, 240 community members, and 60 healthcare providers. And I'm saying this because I want to say that we have created this evaluation system that allows us to collect impact data for each of these populations. So we look at particular domains of change for young mothers, for community members, and for health providers, but then we also have overarching indicators for all three populations. For example, across our implementation in Syria and Nigeria, the two global indicators that we looked at for our three populations are the support for girls' use of family planning and support for girls' ability to exercise their reproductive rights. And we saw increases across all participants for both those indicators. And I'm not going to go through these numbers, but I just want to share we also have the ability to delineate this data by particular target group. So for young mothers, we looked at three particular domains. For example, self-esteem, their ability to communicate, and confidence-seeking healthcare, and we saw increases across all three. For community members, we also looked at three indicators that were their ability to recognize unequal gender and social and power norms, then their interest in changing those norms, and their ability to support girls' equal access to services, and we saw increases across all of those three. And for healthcare providers, we looked particularly at their comfort providing family planning to adolescents, their support for girls' choice to use family planning, and their recognition of their individual ability to influence a girl's ability to exercise her reproductive rights. We saw increases across all three, but I just want to highlight for a second the health providers themselves. So oftentimes when we work in humanitarian crisis context, what we see is that girls are telling us when we do our initial needs assessment that they have two major barriers to being able to access reproductive health services. The first one is permission from their husbands or mothers-in-law, and the second one is the attitudes of the healthcare providers when they reach facilities. And when we were doing this program, this needs assessment, we realized that it's not, from a healthcare provider perspective, it's not just the attitudes, it's also the structure of the entire system that potentially creates barriers for girls to be able to access services. For example, a girl would say, well, I know who the healthcare provider is, and she knows my mother and mother-in-law, so I would never go to her because even if I did, everybody in my community would know that I was accessing family planning. And so one of the major, to me, the super exciting things that came out of this changes that we were seeing with the health providers was that they would tell me things like, we've actually changed the way our clinic runs to be able to better accommodate adolescents. For example, from certain hours, we only see adolescent clients, which means nobody else in the community can physically be in the clinic at the time that the girls are in there. They sometimes have separate entrances if they can afford to do that. They have confidentiality spaces. They have privacy screens. Basically, these things that didn't exist before have come in because of this training process. And I realized that an evaluation like that, while it's overwhelmingly amazing from my perspective, it is still subjective. So what CARE did is that we complemented our subjective evaluation by also collecting data from actual health facilities. So what we did is we went to health facilities that were in the catchment areas that Amal had been implemented and said, please provide us your data for all of your clients who are adolescents and show us before Amal was implemented and after Amal was implemented the rates of your client proportions that are adolescents for all family planning services. And I'm super, super pleased to say that we saw across all implementation sites that the rate of adolescent uptake of family planning doubled in health facilities where Amal was being implemented. The table here shows you that there were increases not just in family planning, but also antenatal care, skilled birth attendance, and postnatal care. I'm going to breeze through this next section, but just to say that in addition to impacts, we also wanted to collect information on what we did for lessons that we learned could have been done better. We looked at 3 particular themes. The first was localization. We wanted to know how could we create the right conditions for us to be able to implement a program about adolescent reproductive health when we know that that's sometimes a heavy topic to bring in. And there were 3 things that we realized we should do. The first is you have to build capacity of local implementing partners. We all know this, but I just want to state it. The second is you have to, especially in a situation where like CARE and UNFPA created this global program and then we're sending it to partners to roll it out, we had to do an intentional job of creating ownership of that program among those partners for them to be able to feel like they could really implement it well. The last is that you had to get buy-in from communities and if you were doing it in refugee camps, then within camp management as well. The second theme we explored was adaptation. Again, we've developed a global program, but then we've implemented it in Syria, in Lebanon, in Jordan. You have to think about the contextualization of those programs. And so what we did was we ran an adaptation workshop every time we implemented in a new country where we adjusted for these 4 things. Language, obviously, the relevance of the content of the curriculum, the cultural norms that exist within that society, and the structure of sessions. The structure of sessions is simple, like in some cases we implemented 8 sessions, in some cases we split it into 9. Finally, we looked at the last theme, which was how to encourage meaningful participation of adolescents, which is the core of what we were trying to do here. And we realized that there are 3 things that are important to this. The first is leadership skills and training, which honestly, most organizations do. That part is not super revolutionary, I'll admit that. But that Amal did that through those additional sessions that the girls were enrolled in if they said that they were interested in doing that. The second is to provide platforms for sharing. So this was unique to this program, as in that the girls weren't just talking to us as facilitators, they were also being able to advise their own community members and healthcare providers through the community advisory groups. So they were able to have direct one-on-one interaction with these very big leaders in their communities. And the last one was collective responsibility, which is when you create, through the engagement of community members and health providers, we were able to create this, essentially this sense where everyone was like, I am personally responsible for what happens to the girls in my community. And that was really effective in engaging and having the girls be basically granted more opportunities within there. And I'll just summarize with these key takeaways, which is that first, younger adolescents are underrepresented in family planning programming. We all know that, and we're going to try and do something about it. The second is, in order to be able to influence the family planning access that girls are experiencing, we have to engage with their networks, the community and societal networks. Finally, I said this already, but just to emphasize that for married adolescents in particular, as a subgroup, spousal permission is very key to their ability to engage with family planning programs. And finally, even in fragile contexts, with and for adolescents is not only possible, but should be a key programming principle in the ways in which we operate. Thanks, everybody.
Thank you, Pari. That was great. We'll move next to Sigma, who will be sharing from Population Council.
The slides, my power slides is coming. So good afternoon, everyone. I'm Sigma Ainul. I'm social and behavioral scientist at the Population Council. Today, I'll talk about the findings from a study that looked into the sexual and reproductive health on Rohingya population. It's a larger study, but specifically my talking points today will be focused on contraceptive non-use among the adolescent and youth in the Rohingya camps after their post-displacement to Bangladesh. And this study is also focused on to see whether there is any change after they have come to the Bangladesh and camp. So their contraceptive norms and practices, whether it have changed or not. And what are the inroads we can make to increase their uptake of contraceptive use. I have several co-authors in this paper, our colleagues. One of our co-authors also present in this room. So Rohingya has been fleeing to adjacent districts of Bangladesh for decades, but the recent influx that happened in August 2017 has increased the population in fourfold in Bangladesh. Currently, 1 million of Rohingya population is residing in 2 districts of Cox's Bazar, mostly concentrated in Ukhia and Teknaf. This recent influx is fairly young. 60% of them are below age 18. When the Bangladesh government has designing the response program after their influx, it has become very challenging because we have very little data on them. Because historically, the Rohingya population has been understudied, part to the fact that they have not been included in the census in Myanmar. So we have very little knowledge about their demographic profiling and what is the practice of sexual reproductive health or family planning or maternal health services. So UNFPA was the lead in the response service for the sexual reproductive health for women and girls. And at the time, they did the profiling, demographic profiling with the ICTDRB. So, and our study was a follow-on of that profiling survey. So by the time we went with our qualitative study, we had some information about this population. So I'll quote some of the statistics from that. So we knew by that time that their early aged marriage is low, like early, and there's early pregnancy also prevalent. We knew that contraceptive prevalence rate is 34% at the time. This is quite low if we compare with our population. And we also found that the facility delivery and sexual reproductive health uptake was low. So after that following survey, we wanted to know in this survey that why, in this qualitative study, that what is the reason or factors behind this low uptake of contraceptive, despite the supply, despite the commodities, despite the response service, government and the development partners are joining hand in the camps. So our qualitative study mainly focused on to explore the factors behind that. What are the normative behavior the Rohingya population have, and what are the factors that they are not taking up the contraceptive and other sexual reproductive health services. So we did this qualitative study in late 2018, and we collected this information from this population in 2 time frames. One is what is the current situation in 2018, what is their contraceptive use and norms, and what they used to do in Myanmar, so that you can understand the change, whether anything has influenced them after their post-displacement to the camps in Bangladesh. The right-hand side of this corner, you can see the maps with the. At the time, the camp was divided into 20, larger camp was divided into 20 smaller camps. And we conducted our study in the 5 of these camps. We did in-depth interviews with Rohingya adolescent and youth, both male, female, married and unmarried. 48 IDI we have conducted. We also did an interview with the program managers and the service providers who were directly working with this population in the camp. There was also 2 influential groups. We also talked with the community leaders and religious leaders, who are the imams, and the community leaders, the majis, who are mostly deal with the administrative operation in the camp. The camps are also divided into blocks, and the majis are in charge of this block. They provide the rations, they do all these administrative things. So they have a strong influence on this community. We also did focus group discussion with elderly Rohingya women to understand their normative behavior of this population, so what they carried through from their generation by generation, to understand all those things. So moving on to the findings, we found that the religious teaching across all of the groups we interviewed, the Rohingya youth and the program managers and the majis, we found that religious teaching has a very strong influence in their behavior and practice. And the dominant religious belief is that using of contraception is prohibited in Islam. That was strongly said by across all groups. I'll read a quote here from a married woman, age 21. The Hujurs, Muslim religious leaders, tell us not to use contraceptive method. It's a sin. Allah made women fertile so that they can bear children. The other aspect that goes hand in hand with this religious teaching is that we found a strong desire that they want to increase the Muslim clan. As they said that there was a lot of killing in Myanmar, so they do not want to limit their children, so they want to increase that. That is another motivation for them not to use contraceptive. Also, the religious teaching goes hand in hand with the misinformation and stigma. And the most common stigma and the fear they expressed is that if they use the contraceptive, it will damage their reproductive system and they will not be able to bear children in future. And this misinformation and stigma is further reinforced by the gatekeepers they have and the religious teachers. So also, we found that there is a strong association they try to make with contraception with immorality or the promiscuous behavior. So in focus group discussion, Ms. Malji was saying that bad people use condom for going to bad place. Why would anyone use condom among family, meaning between husband and wife? As I was saying, that the religious teaching also reinforced by the gatekeepers. And in this Rohingya community, husband and mother-in-laws are the strong gatekeeper, and they have a key role in deciding the fertility choice of the woman. I'll read a quote here from a married woman, age 20. I wanted to have pill, but my mother-in-law restricted me. She says, I will die. My husband also did not let me. I tried several times in secret, but could not. Women want relief in their body, but husband and their family want children. They say it's Allah's order. So moving on to the, as I mentioned, that we also tried to explore whether their norms or practices have changed after coming to the camps in Bangladesh. So what we found that being in a transient state after coming to this camp, the norms have changed a little bit. There's some indication of that. And I'll read some of the quotes from a married girl, age 19. In our society, people think more children as a good thing. This is Allah's will. But the case is different in camp. Here, living space is small, shortage of food, no money. Living condition is constrained and hard here. Women here should use contraceptives. We also found these indications in our focus group discussions with Majis. I'll just read a quote here. We are now in a miserable time, neither Bangladesh nor Myanmar. We are now of nowhere. If they drove us now, where will we go with so many children? For this, women are now using contraceptives. It has also with this, there was an increased supply in the camps, which they're not able to get in Myanmar. So there's increased availability of contraception, the service providers also active. So, and also that with the supply, there is also some influence of the group behavior. Some women are using it and the others are also seeing it. So that influenced a little bit on use of contraceptives in the camp. I'll read a quote from a married woman, age 20. More people are having pills here in the camp. Use of depot is also more than before, meaning Myanmar, because it is easily available here. Birth spacing is good for both mother and children. I think everyone should use it because now nothing is like before. Also, the thing we found in our qualitative study that sometimes the right messaging was key. Sometimes in the FGDs with the religious leader, we found that they do not approve of birth control. This is strictly prohibited in Islam, but birth spacing is allowable for the health benefit of mother and children. So sometimes they use that those courses. They acknowledge that yes, in Islam there is a space for birth spacing if the mother is not well in health and if you have to, it is difficult for taking care of the children. They also mention about that Islam says of 2 years of breastfeeding so that you have full nourishment. So there are some space where we can make those inroads to access this population with their right sentiment. Also, we found that certain contraceptives are more acceptable than others. And there are some reasons behind that. So one woman was saying in the focus group discussion, we have heard of implant. It is taken for 4 to 5 years, but we are afraid to receive this. If we insert and then if we need to go back to Myanmar, how can we remove it there? Who will help us? This fear works in mind. If anyone dies with it inside body, that it will be of great sin. So the findings suggest that um, there are several ways we can um, um, use to to remove the stigma around that, to remove the misinformation. And so that we can, first we have to understand their sentiments, where they are coming from. Like if the stick is here, if she dies, then you'll be seen. But control is not acceptable, but spacing is allowable for the health of mother. So using those things, we need to provide them the right information so that the stigma is on the contraceptive use is removed. So also found that there is a lack of knowledge and understanding about the contraception. So community health education need to be prioritized. That has been said by both the program managers and also the Rohingya women and males. And engaging these different actors is important. As we said, there are some very influential people, like the religious leaders are very strong saying that. Majis are very influential. And also we saw that the husbands are the strong gatekeepers. So to reach the husband group, we can use this Majis. And that is what we are doing now in many of the NGOs are working with Majis. So that they, and we have to pick the progressive ones so that they can work with the husbands and so that the community education can be provided. Also the Rohingya community is very conservative, so it's mostly male dominated. So to diffuse the effect of completely male, we need to also bring into some female in the group, and mostly the elderly women, if we can increase them in their awareness and knowledge, because the mother-in-laws fall in this group. So that's how we can increase this knowledge of this population. Also, the other thing we have to understand, this Rohingya community, even in Myanmar, they're not very habituated to go to the health facilities. So no matter how much health post or how much community you are providing at the supply side, we need to go to them. So more outreach work needs to be done along with this community health education, so that we can get to community. And also including the volunteers from the Rohingya community, along with the Bengali health workers, will give them the trust that we can gain access to this community better. And considering the low literacy level, more health, more audiovisual education material on SRHR and family planning would be more effective. So I'll stop here. Thanks for your patient hearing.
Thank you, Sigma. That was really interesting. We're going to move from Bangladesh over to Indonesia. I'd like to invite Moody to come down and present on the cyclone Saroja. Thanks.
Okay, good afternoon, everyone. I'd like to introduce myself again. My name is Modi Taupan. I came from Indonesia, from IPA. As we know that IPA is one member associations of IPPF. And now as the executive director of IPA chapter East Nusa Tenggara since 2018. But I'm getting involved with IPA since I was in junior high schools. In 2003 as a peer educator and a peer counselor of IPA East Nusa Tenggara province. I'd like to share about our peer educators did to promote adolescent reproductive health in emergency in Sabah Regio response. So if you can see it in my first slides, there is number of youths. They are the peer educators and the peer counselors of East Nusa Tenggara province. They are the team that work for the Saroja response in East Nusa Tenggara. And for the another picture was the activity that they did at the tent at the IPA camp in Sabu Rejua Island. Yeah, let us see the map of Indonesia. Here is the map of Indonesia. And for the pictures at the right of us is the East Nusa Tenggara province. That's the province that separated by the sea. So if we want to go to another district, then we have to use the ship or airplane. Because of the, the geographically, this is East Nusa Tenggara province. So the picture below the East Nusa Tenggara province is Sabu Rejua district. That is the place that we set up the tent there for a humanitarian response. It is about 8 to 12 hours from the capital city of East Nusa Tenggara province, where IPA East Nusa Tenggara province office is in Kupang, and yeah, I work in Kupang, but then we have to respond in 8 to 12 hours far away from Kupang City. So what's happened with East Nusa Tenggara province? So this is on April 4 to 5th, 2021. There was a tropical cyclone named by Seroja, and it swept out East Nusa Tenggara province. So the tropical cyclone itself resulted a heavy rain, hurricane that uprooted the trees, floods, and also landslide in 21 districts in East Nusa Tenggara province. So here is the impact of the TC itself, TC Seroja itself, that the data we get from the Prevention and Preparedness of National Disaster Management Agency, or in Bahasa we know it as BNPB Indonesia. The data we got on April 12, 2021. So through the IPPF Sprint program that funded by DFAT, IPA East Nusa Tenggara province start to do the humanitarian response there in Sabu Rejua Island. So we set up the tent at the Sabu Rejua Island. We bring the medical team and also the social support team, but also the number of youths that we know is as the peer educator and peer counselor of East Nusa Tenggara. Why? The reason is the two point there, that we recognizing the number of the youths in Indonesia is about 26% of the total population of Indonesia. So it's like a big number of the youth. So we recognize their powerful and their capacity to help the society. And it's also happening in East Nusa Tenggara province that 26% of the the youth population is, the number of youths is about 26 from the total population in East Nusa Tenggara province. And then the second one is that IPA believes not only IPA is Nusa Tenggara is Nusa Tenggara itself, but also hold the IPA chapter in 25 provinces in Indonesia. We believe, he do believes in young people and support and also facilitate the young people to learn about sexual and reproductive health and rights, and also with various issues related to the young people's life. One important thing is the issues related to the get ready towards disaster, or in Bahasa we know it as siaga bencana. So they can be able to know what to do if there is a rain for more than 12 hours, for more than 5 hours, what to do. So it's kinds of like education that we also give to them, so they can be more empowered with that information. And then the second one is that we train them to be empowered. So uh, train them to be the peer educator, not only for SRHA itself, but also for be aware towards the disaster around us. This is like the pictures of what the peer educators and peer counselors of IPA East Nusa Tenggara province has. The first things that they did is they conducted a series of awareness and education sessions at the camp with the local youths around the disaster areas. And then the second thing that they did at the time was they teach the psychological first aid and offers mental health and psychological support to the affected youths, but not only the affected youths itself, but also all of the society in the disaster area. Um, our peer educators and peer counselors are actively utilizing the social media, such as Instagram, Facebook, and YouTube to disseminate information and awareness. So this is I capture the Instagram and also the Facebook and the the YouTube channel that my youth group in East Nusa Tenggara province has. Last but not least, the peer educators also help other youths to access needed referral services in the disaster areas. So this is one pictures that we took it at the time where the young girl comes to the counseling rooms to have a counseling with our counselor. So the program resulting we reach out about 2,000 direct and like 13,000 indirect beneficiaries, where 700 are young people, that including marginalized communities, that the peer educators and peer counselor in IPA are not only recognizing the youths come from the general youths, but also they are teach to be more inclusive, so they can also embrace the marginalized groups, marginalized communities. So from Sabo Radio itself, they also engage the disabilities group and the gay and transgender youths. And the local youth in the disaster area are enjoying discussion with the peer educators of East Nusa Tenggara province, peer educators, because they are in the same age, and then we know that at the same age, and then they can speak freely and speak openly to their friends. And one strategy that they try to implement at the humanitarian setting was because the number of the population in East Nusa Tenggara province, 90% is Christians. So they try to decided as one strategy that what they have to do. They come to the religious leader asking permission about to go to the youth club, youth communities in every church, and then they made us as awareness sessions with the youth community in every church. So that's why they can reach more youths at the disaster area itself. So as the lesson learned of our response in Sabu Radio in Saroja is that young people are showing a high level of interest to engage in every activities. Where I remember that after 3 days after the Saroja swept our province, when I came to my office, then I saw like 10 to 12 youths are sitting there, and then they're asking me about what can we do for our community. So I think that is like a very interesting thing that the young people can do. If we empower them, then they can give us more, valuable things that they can do. And then we can support them by training to maximize their capacity, and we have them chance to come with any inputs in every phase that we have, like starting from the planning, implementation, up to the monitoring. We involve them to be with our team. So last but not least, I am going to encourage all of us to let's do a human investment by involving youth in our program, because young people involvement is a human investment. I raise my presentation. Thank you.
Thank you, Moody. Really interesting peer education design. Thanks so much for that. And we'll move on to our final presenter, Herbert, who will be presenting on the Uganda context. Thanks.
Good afternoon. My name is Herbert. I work with International Rescue Committee in Uganda. Today I'll be sharing our experience and lessons regarding increasing access to family planning for adolescents. This is work that was done under the Wish to Action program, where IRC is one of the consortium partners led by IPPF. We all know that in the humanitarian context, access to family planning for adolescents is key. And we know that the risks to unintended pregnancy and its consequences are very high for adolescents, basically because of some peculiar characteristics, like their high risk-taking nature, forced sex, but also on the service side, looking at the reduced availability, but also the reduced sensitivity to adolescent sexual and reproductive health needs. So under the Wish to Action program, it is key, in the spirit of leaving no one behind, we set out to reach adolescents below the age of 20. And there is a set target, and we're looking at having at least 15% of all users being under the age of 20. So in Uganda, and also South Sudan, but I'll be sharing more of the Uganda experience. Over time, we're stagnating at about 14%, despite a number of interventions that were targeting the youth. We're seeing an increased number of services to clients in general, 1,000 a month, 3,000, 9,000, but the proportion of youth was not increasing. And this led us to thinking about how we are implementing and to re-examine the approaches. This birthed the idea of a user-centered design sprint approach, where this is a rapid process of answering critical behavior, program, and service questions through designing, prototyping, and testing with the users certain ideas that would improve services or yield the results that you're interested in. So in this presentation, we'll be looking at the journey that we took. We'll look at the outputs and also the lessons that we learned from this experience. And key was to ensure that we increase service uptake by users below the age of 20 in Uganda, but also the same exercise was done in South Sudan. So the journey basically has those components where we start from problem identification, solution identification, prototyping and testing. But along the way, we realized that among the ideas that we're testing, we birthed even a bigger problem, which required even a bigger solution. And then we had to go into a second round of prototyping and testing, and then finally coming up with actionable ideas and making them implementation ready. So I'll just go quickly through these. So problem identification basically involved a series of interviews with adolescents, service providers, community, religious leaders, and policymakers. And basically here the questions were about what is happening on the ground, what we're doing, how do they view it, what would they want to see, and what are the key barriers towards access to family planning. So this yielded so many gaps, but also giving us an insight to what the possible solutions could be. And here, on the solution identification, there are certain things that the adolescents described as what they would view as a good service and what would actually drive them to receiving services. Some of the things we see: parental support, access to services, feeling welcome, the nature of counseling, and you can see the pinpoints down. For example, parents are misinformed about the effects of contraception on fertility. Social norms associate contraception with many sexual partners, etc. So looking at all these, we decided to aggregate the barriers in relation to what a good service would be. And this birthed three key constraints. Contraception services are not for me, based on a number of thoughts and ideas from the adolescents. I don't feel cared for when I go to the facility. I don't want others to see me, the issue of privacy and confidentiality. And these formed the top ideas because it was about prioritization, but also looking at the gaps that created the biggest impact or that were highest on the list. So the solution identification, we aggregated the ideas and themes into these three key ideas, where we're looking at the need to have a trusted person as a connector, looking at youth ambassadors or youth-only mobile services, because we're looking at access, we're looking at confidentiality, we are looking at how welcoming the services are. But also on the side of information, we're thinking of a mixed media outreach to be able to improve information dissemination. So we went ahead and tested these ideas with the adolescents and providers. We ended up actually getting an even bigger problem. The bigger problem was here. The adolescents felt that we needed a system and a culture that ensures that the services and activities are centered. But the question is, how do you do this? And from the interactions and interviews, we realized that it is important to set principles that make sure that this environment or this system is created. But on top of that, we also need an accountability system that will check and ensure that actually the system is in place and it is functional. So This became our new idea, and we went back to prototype and test again with the users. And what matters to youth when accessing contraceptives? These were the key points that were raised and aggregated to these topics or themes. Gender-balanced engagement, service in private spaces, youth-centered and gendered pathways to services, services by gender of their choice, and lastly, accurate information about contraception. And you can see some of the quotes from the different users against each of these themes. So this, we got a key takeaway. As much as the service was available, uptake wasn't dependent on just the availability, but on the quality and the culture of the service providers that we have or the service that is provided. So this led us to thinking of creating that system that I previously talked about. And in the next slides, I'm going to share some of the outputs of this design sprint. They are mainly 4 outputs based on the different points in service delivery and also the individuals involved in this service delivery. The first is for the providers, the first actions or outputs. Then for the youth ambassadors, because if you connect the system and also the accountability mechanism, we needed an interface between the user and the facility or the providers. And then, of course, for the planning teams, us who are implementing the project, and then mechanism for monitoring and evaluating this particular system and process. So, on the side of the providers, this birthed what we called or termed the 5 youth promises. A set of principles that would govern the service delivery for adolescents within our facilities. These 5 are here. The first is that youth will be served by the gender of their choice. Secondly, we'll provide true and accurate information and correct any false or inaccurate information. Thirdly, we'll provide services in private and with one person in one place. And we'll keep all identities and discussions secret. Number 4 is that we'll create different ways to access our services that helps both young men and young women comfortably. And lastly, we'll make decisions by asking and listening to young men and women equally. So we also developed what we'd call a user guide or a reminder, such that this becomes institutionalized and is at the back of the mind of every provider. On top of that, we also tasked the youth ambassadors. We gave them 3 key roles. Number 1 is holding service providers accountable to these 5 youth promises. 2 is supporting the service providers to keep them, to act as checks and balances, to let us know where things are not going right. And then lastly, they themselves upholding these 5 youth promises when they are interacting with their fellow youth. And these are the 2 user guides for both the provider but also the youth ambassadors. And then on the implementation side, we also had some very interesting outputs. As I told you, for quite some time we're stagnating at around an average of 14% of all our users below the age of 20. So from the time we started implementing the 5 youth promises, you can see this spike up to about 21%. And this was up to, this data is up to August 2021. But I can tell you that it has continued to spike to about 26% currently. And I believe in South Sudan it's even higher than that. So this has supported us in improving our youth reach, but also the quality of services that are provided to the youth. So, key lessons learned. What we can say is that a design sprint approach is very feasible and acceptable within the humanitarian context and yields very good results, including community stroke adolescent led and accountability mechanisms. The first learning is that running a design sprint with existing teams and programming requires careful scheduling and budgeting of time and resources that are both manageable and flexible based on the staff capacity. It's a lengthy process. It's tedious, so it needs proper planning, and we have a number of recommendations or ideas which we can use to ensure that this is done. Secondly, is that a large team collaborating both offline and online works best with designated team members, and these designated team members need to be context experts. They need to be to have very strong relationships with the users, and they need to be in touch, physical contact with the users. And some recommendations are here on how to best do that. The third one is that we acknowledge that not all members will be at the same level in terms of this design thinking. The most important is to introduce this approach in a very familiar manner for those that are not conversant with the design thinking. Show them the importance and what hurdles it is going to clear within their work. And then lastly, co-design with them so that they understand and own the process from the start. Number 4 is about, I said we did this for 2 countries concurrently. A multi-country design sprint will lead to valuable learning about clients and different contexts. However, each country or each field site should run their own design sprint and, should be tailored to their context. And lastly, addressing a culturally sensitive topic such as this one, as an organization may require deeper relationship building with clients, because we basically need the clients to be as honest and as open as possible so that we get their perception and act in line with their desires. So it requires that you have a very close relationship with your users to ensure that you pick out the best and the accurate information from them. Thank you. That's it.
Thank you, Herbert. That was really interesting. We have heard a lot about different interesting models here. And just as a summary, we heard from Pari about the Amal initiative to engage young mothers in Syria and Nigeria. From Sigma, we heard about qualitative study findings for barriers and opportunities for the Rohingya in terms of contraceptive uptake. We heard from Modi, from IPA, Indonesia response related to the peer educators design model there and the various activities, engagement of marginalized groups as well. And then from Herbert about the design sprint model to improve youth engagement and co-design and co-ownership in Uganda for South Sudanese. So this is really fabulous, first of all, very exciting. Thank you for those contributions. Opening it now up to the floor for reflections, questions, answers. We have a mic in the middle of the room. I think we'll go ahead and, sure, go ahead, Nerida.
Hi, I'm Nerida from the IPPF humanitarian team, Julie's team. Also an ex-Care Bear, so I really enjoyed your presentation. Pari, I have 2 quick questions for you. I really like the Amal project. I think it's a really lovely project. I'm wondering whether, all the contexts that it's been rolled out in are very protracted crises, whether you feel like it could work for an acute setting. And the other question is, it's obviously very empowering for young mothers and changing their behaviours. Could it also be used to prevent or change behaviours to prevent early marriage and early pregnancy?
Thanks. Yeah, I really like the ML program too. I often joke that if I ever left care, I would have to take it with me because I feel too strongly about it. So your first question, I think it could have very easily work in a short-term crisis as well. It wasn't designed necessarily with a protracted crisis in mind. It was designed to say what works when there is a crisis, and that means, like, even short-term and long-term crises have what I believe is the same conditions but at varying degrees. And so I think our adaptation process would just look slightly different if it was a short-term crisis, but yes, it was designed to work in both. And the second one is so the primary intention of the ML initiative is to increase family planning use amongst married adolescent girls. It is not designed to combat early child forced marriage, but as a consequence of doing this work, one of the things that we heard during our qualitative evaluations with the girls was so many girls would say to me, like, I will never let my younger sister get married until she's a certain age. And so we have actually, as the second phase of the ML initiative, started to think about how to incorporate one additional session into the curriculum about ideal age at marriage, while also acknowledging that there's many contextual things that contribute to that. So my short answer is it's not intending to do that, but it is something we're starting to see as an unintended consequence through the data. So I think there's room for it to grow to potentially be a program that also tackles CEFM. Yeah, thank you.
Thanks, Pari. Other questions, reflections from the floor? Sure, go ahead.
Thank you very much. My name is Wilson Senyonya. I work with Oxfam in Uganda. My question goes to the second presenter who presented from Bangladesh. One of the challenges that you did mention was on the religious beliefs that people have. So I wanted to find out if you have any special plans to engage religious leaders to make sure that they understand and appreciate the importance of family planning. The same also goes to the cultural leaders or clan leaders, in case you have them. Are there any engagements that you have with them? Because many people do believe in them, so that you are able to engage them and then they appreciate family planning. And the last but not least, I'm wondering whether there is sexuality education in Bangladesh in schools. Is it allowed? Because I understand in some countries, sexuality education is actually not allowed. So if it's not allowed, what is your role are you playing in terms of policy formulation? And if it is allowed, how far are you engaging the different stakeholders to make sure that within the schools, family planning is part and parcel of the curriculum, so that the children and students appreciate this from the early age? Thank you.
Yeah, thank you. About the question that the religious leader, how to involve them, it has been already started. When the NGOs who are and the service providers who are working, we have in this room the RTMI, the largest health sector and sexual reproductive health providers in the camps, both in Rohingya and host community. So the religious leaders, engagement of religious leaders, and after this need assessment, it has been identified that religious leaders have a very strong role. So through the community meetings, through the courtyard meetings, they're trying to engage the religious leaders. That's the process that each of the NGOs who are, because these camps are subdivided. In some of the camps, the RTMI is providing, some camps, the CARE is providing. So there's the intersectoral coordination group of the SRHR. So and also there's a strategy that has been developed with government and the UN. So these has been very emphasized in the current strategy that is for future even. that engaging the religious leaders and engaging the other actors like the Majis, and through the community health education in the courtyard meetings, they are providing the sessions, awareness raising sessions. But more need to be done, that I will add. And about the sexuality education, there is, I missed that whether you are talking about the camp setting. Still now it's more of the service provision. What we strategy we see that more community health education needs to be provided and more outreach. And there is not sexuality education as such, but the SRH sessions are being provided through the volunteers, through the community health workers when they go to door-to-door service, but not really that much structure. That is we are trying to increase, and that we are advocating the researchers and other communities.
Thank you, Sigma. Yes, question here.
Ahmed Al Kabir from Bangladesh. I'll start with Sigma first. That is, you have made a very good presentation about the present situation in the camps, particularly the Myanmar refugees and forcefully displaced people. But is it possible to make presentations for the service providers in the field so that you can really disseminate those policymakers and service providers, those who are implementing projects in the camps, so that this will be helpful for them to guide them to develop in their future projects, because the findings of your study will be very useful for the service providers there, and if you can disseminate it there with their interactions, probably that will be helpful. So that's number one. With Puri, I was thinking that is, while you are making this presentation for family planning, the same model also can be applicable with nutrition and few other interventions independently, if those who are implementing not only just family planning, comprehensive other interventions as well we are implementing, particularly in the refugee settings. So these toolkits and others are available also for the people, those who are implementing, and how we can access those things so that your presentations as well as the toolkits and others can be more widely been circulated so that we can adopt it where we want to in our setting. Thank you very much.
Thank you, Dr. Ahmed Al Kabir. Yes, rightly said that the findings we normally present in the research forums, but we also do present these things in the field. When we did this study, after that, we presented these findings at the camps with the RRRC, who are the leaders and engaging the other implementing partners. RTM was also there. And more so the service provider, as you rightly mentioned, who are providing this facility service, plus the outreach service. As a second stage of this study, recently we have conducted the life skill and SRH training for the Rohingya community. And then these findings of the study will also be shared into the monthly meetings of the SRH working group, network working group, so that that can be more disseminated. And the real time they can use the information about how to make these inroads through the engaging of the Majis, through the engaging of the husbands. So these things are being disseminated. And about the nutrition, rightly, those things can be done who are interested in the nutrition group.
I'm really glad you brought up nutrition, because I think that, especially in the humanitarian context, when we as family planning practitioners think about family planning, one of the things that I struggle with when I'm trying to get donor funding for a program is that there's such immediate needs like malnutrition or lack of shelter, is that sometimes people don't see family planning as the primary focus of what they should be doing. So I think it's actually an opportunity for us as family planning practitioners to think about how to potentially integrate nutrition into our programs. And Amal has started to do that because our primary donor, BHA, told us that that's what they want to do in Nigeria. So we are actually currently in the process of developing a new component for the Amal initiative that is specifically focused on nutrition for young mothers. So clearly you're in the same mindset as us. And the toolkit is freely available on CARE's website. You just have to Google CARE Amal Initiative. It is available in English, French, and English, Arabic, and Spanish at the moment, but will be translated to other languages in the future as well. The toolkit, like I said, it's the curriculum for all 3 components, plus all of the evaluation tools and a standardized set of data analysis templates. So it's all on there, and the idea is that any implementer can take this program that CARE developed and start to run it in their own community, and they can even come to CARE for technical assistance should they need it. And that's exactly what's happening in Jordan and Lebanon. It's actually being taken on beyond CARE by other organizations. So that's very much the intention. Thanks for the question.
Thank you. I think we have time for 1 or 2 more questions. We have 5 more minutes in case there are other reflections. Okay. Taban, my old friend. Go ahead.
Yes, mine is not question, but it's a comment. I just want to say, these have been a very great presentation from all the presenters. What I've seen from the 4 presenters and what I've observed is all about, getting attention of youth access to access family planning services. It needs, innovation and creativity. So if you just look through the 4 presentations, each presentation has its own way of approaching youth and how, to draw the attention of youth access to the family planning services. So I would like to, urge all of us, to learn from this, more especially the youth spring design, where Uganda was really doing very bad. We did the spring design together. I was in South Sudan. And we have seen a very great change, not only in Uganda, but also in South Sudan. As he mentioned, as of now, we are standing at 32% of youth accessing family planning services, on quarterly basis and on like every time we did analyze, and that's where we are. So it's a very good take up, and we'll always be happy to say our comments and to interact. Otherwise, thank you very much and great work done.
Thanks, Taban. One final question here. Yeah, okay.
Obaidullah from Population Council, Bangladesh. As you know, with the changing global context, refugees are moving from countries to countries, and it will not stop today or even tomorrow. If you think about Rohingyas, there are 1 million people residing in a camp, which is same size like several African countries. So and even in Bangladesh, the largest, smaller cities are not 1 million population. So if you think that way, how to reach those SRH with SRH component or nutrition component towards displaced people is not only the displaced people due to climate, due to this, conflicts, but it could be due to climate change also. Due to climate change, people are also displacing. So as you mentioned that, tools and other things could be more widely shared, and this type of, discussion should be more openly discussed so that it should not be contained within the organization. It seems to me that in some those settings, we have looked at 5 countries of the largest Rohingya concentration, largest refugee concentration, like Ethiopia, Sudan, Malaysia, where the large concentration of refugees are there. There is a strong need for these, types of programs so that, these temporarily displaced people, sometimes we permanent in Rohingyas are there for last 5 years. Every year, 30 to 40,000 children are born. So if you think about that way, quickly in 10 years' time, there will be another 500,000 newborn addition with the 1 million. So definitely it should be a great idea if you can put all organizations like CARE and others in a consortium so that other people can share from their findings. Thank you.
Great. Thank you so much. I think we'll end on that note. This has been really enlightening. Thank you again to all of our panelists. Lots of really interesting models, protracted settings, acute emergencies, lots to reflect on. Please take these conversations and thoughts into the corridors and through the next few days. And thank you so much to the panelists. Thank you for the engagement from the floor, and have a nice evening. Cheers.